Here is a case of a 60-year-old female with complaint of jaw pain and ringing in her ears. She saw an ENT who could not find any ear pathology. For the history of the present illness, for the jaw pain, the onset of this pain began about 11 months ago. She believes the causation is from stress or clenching her teeth. The location is both sides of her jaw. The pain quality is more of a tightness or a soreness. The frequency is usually in the afternoon and until bedtime. The severity of the pain is moderate. What makes this pain better is taking lorazepam, and what makes it worse is stress. For the history of present illness of the ear ringing, this also started 11 months ago. Again, causation could be possibly stress-induced. The location is both ears. The quality is a pressure ringing sound. The frequency is in the afternoon, and it lasts until bedtime. However, she mentioned that this noise sometimes keeps her up at night. The severity of the pain is moderate. What makes it better is again lorazepam, and what makes it worse again is stress. For her sleep history, she does state she has insomnia. Her past medical history is positive for interstitial cystitis, gastritis, arthritis in the hips and back, tendinitis in the ankle, anxiety, cold sores, high cholesterol, vertigo, and seasonal allergies. No known drug allergies. Medications that she's currently taking include Ambien, lorazepam, Lyrica, Celebrex, cyclobenzaprine, pravastatin, and Welchol. Surgeries include C-section, plastic surgery, and epidural blocks. Her family history is positive for heart disease and cancer. For the social history, the patient is not able to relax during the day. She admits to daytime clenching. She is a small business owner, which can be very stressful. For the palpation of the craniofacial muscles under the extraoral exam, I found that the right masseter had 6 to 7 out of 10, which is moderate to severe pain, and it referred to the right TMJ. The left masseter was 5 out of 10 moderate pain, referred to the left TMJ. The right temporalis tendon had 8 out of 10 severe pain, and the left SEM had moderate pain that referred upward. When palpating the temporomandibular joint, there was mild pain to both right and left dorsal condyle. Examic glands were all normal. Assessment of facial, jaw, and occlusal structures were normal. The max pain-free open for this patient was 46 millimeters, which is normal. The right-left lateral max was 10 plus millimeters, which is normal. Her overbite and overjet were 1 millimeter, and no TMJ noises were detected with the stethoscope. During the intraoral exam, inspection of the oral tissues, the gingival, alveolar, and mucosal tissues showed a scalloped border of the tongue, as seen in this picture. There was no obvious dental attrition. Posterior tooth contact with molar was normal. She was in a class 1 occlusion. Salivary function was normal, and in this case, no radiographs were taken at this moment. For the diagnosis, I diagnosed myofascial pain and tinnitus. For the plan, I gave her myofascial protocol with avoidance therapy and stretch and rest, I recommended heat therapy for the muscles, and I recommended a course of Flexerol. I recommended possible future trigger point injections and possible future referral for stress management as well. For the prescription, I gave her Flexerol 10 milligrams, 10 tabs, take 1 tab at bedtime for 10 days. Patient is to follow up in 10 days to evaluate symptoms. Visit number 2. So the patient states the Flexerol actually helped the tension in her jaw and decreased the tinnitus for a couple of days, but it made her too drowsy, so she quit taking it. The myofascial pain still existed on the masseters and SCM bilateral, but more severe on the left side. My assessment was the same, and for the plan, I recommended trigger point injection into the left masseter and left SCM. Patient agreed, consent was signed. I injected 0.5 cc's of 1% lidocaine without epinephrine into the left masseter. Then I injected 0.5 cc's of 1% lido without epi into the left SCM. Patient did well from this treatment. There were no complications. I recommended referral for stress management with the psychologist as well. I spoke to the patient on the phone regarding her symptoms. She feels her jaw pain is manageable. She's doing the exercises and the heat therapy. She states the trigger point injections helped her with her jaw pain, but the tinnitus only decreased for the first day. She's working on her stress management, and she will make an appointment if her jaw pain becomes unmanageable. So what is tinnitus? So tinnitus is the perception of sound within the ear, the ringing in the ears, with no external sound is present. So some common causes include noise-induced hearing loss, that's the most common, neurological damage, ear infections, stress could be one, and in this case, with our stress reduction protocol, muscle relaxers, as well as benzodiazepines, all these things actually help the patient. So in this case, the possible etiology of this tinnitus could be stress-induced. Tinnitus can also be caused by foreign objects in the ears, nasal allergies that prevent or induce fluid drain, and wax buildup as well. She did see an ENT and no pathology was found. Well, what is the relationship between TMD and tinnitus? So multiple studies have shown an association with TMD and tinnitus. So there was a study by Wright. In this study, there were 200 TMD patients with coexisting tinnitus, otalgia, dizziness, and/or vertigo. They were asked about their otologic symptoms, characteristics, and associations, and were given clinical tests which were speculated to predict the otologic symptom response from TMD therapy. The subject received conservative TMD therapy in a manner that was thought would be best helpful for their TMD disorders. After their TMD symptoms improvement, the percent of subjects reporting significant improvement or resolution of their tinnitus was actually 83%. For otalgia, it was 94%, for dizziness, 91%, and for vertigo, 100%. So, significant correlations for tinnitus, otalgia, and dizziness improvement with younger age for tinnitus and otalgia improved with subjects who related that their otalgia symptom began when TMD symptoms began. And it was worse when TMD symptoms were worse, and was related to stress for dizziness improvement with subjects relating to more severe TMD symptoms. So they concluded that asking TMD patients with coexisting otalgic symptoms these specific questions will help practitioners identify which otalgic symptoms have a high probability of benefiting from TMD therapy. Regardless, we always treat the TMD, which is what we're supposed to do, and if the tinnitus does not resolve, then referral is necessary. What about TMD, sleep bruxism, and tinnitus? A cross-sectional study was done to investigate the association between sleep bruxism, tinnitus, and temporomandibular disorder. 261 women subjects with temporomandibular disorders were used to classify TMD and self-reported tinnitus. The sleep bruxism was diagnosed by clinical criteria proposed by the American Academy of Sleep Medicine, and the results showed an association between painful TMD and tinnitus that was statistically significant. With regard to sleep bruxism, the association was of lower magnitude, but still significant. The concomitant presence of painful TMD and sleep bruxism was associated with higher degree of tinnitus severity. So it was concluded that there is an association between sleep bruxism, painful TMD, and self-reported tinnitus. However, no relationship of causal nature could be established.